Thank you for visiting MD Training at Home's echocardiography resources. This module will discuss 3D evaluation of the mitral valve. The advances in probe and software technology now allow for a more detailed assessment of the mitral valve. 3D imaging provides the advantage of better defining spatial relationships of the anatomy, which helps better define the extent and mechanism for some valve disease. In this video lecture, we will take a look at the mitral valve in 3D and discuss what normal and abnormal valves look like. Several case examples have been provided for illustration. The normal mitral valve has anterior and posterior leaflets. The base of these leaflets is attached to a fibromuscular ring, and the free edges of the leaflets are attached to the subvalvular apparatus. The anterior leaflet is semicircular and larger in size, but narrower bases only attach to 1/3 of the annular ring. The anterior leaflet is divided into the A1, A2, and A3 scallops. The posterior leaflet is a quadrangular shape attached to approximately 2/3 of the annular ring and divided into the P1, P2, and P3 scallops. The A1 and P1 scallops are anterolateral and located closest to the left atrial appendage and anterior commissure. "3D transesophageal echo is a valuable tool for accurate localization of the mitral valve anatomy, assessing pathology and guiding valve repair. This example provides mitral valve views from the left atrium and left ventricle. From the left atrial perspective, the 3D image is displayed with the mitral valve leaflets in center, aortic valve is superior, left atrial appendage is left, and tricuspid annulus is to the right. In this example, notice the pacing wire coursing toward the right ventricle. Slight rotation of the data set brings the aortic valve into view. From the left ventricular perspective, the outflow tract is nicely visualized. The following data sets demonstrate abnormal valves as visualized using 3D ultrasound imaging. There are two main causes of mitral regurgitation: primary regurgitation that is caused by an abnormality of the valve apparatus, or functional or secondary, which is recognized by a normal mitral valve and an abnormal ventricle. The mitral leaflets are usually tethered by outward displacement of the left ventricular walls and papillary muscles, with or without annular dilation. When evaluating mitral regurgitation under 3D ultrasound, remember the following tips. Flail leaflet is usually associated with severe mitral regurgitation, and severe mitral regurgitation is rare with an anatomically normal mitral valve and apparatus. Mitral valve prolapse is the most common cause of mitral regurgitation referred for surgery in the Western world, and is found in 2 to 5% of the population. Rheumatic mitral regurgitation is more common in developing countries, where most cases of surgical valve disease are attributed to rheumatic etiology. Mitral valve prolapse is defined as anterior or posterior. Anterior mitral prolapse is greater than 2 mm in the long axis view, or greater than 1 mm in the 4-chamber view beyond the mitral annulus. The posterior directed jet will be seen with color Doppler. Posterior mitral prolapse is greater than 2 mm past the mitral annular plane in the apical or peristernal view. The anterior directed jet will be seen with color Doppler. We are often unable to fully appreciate the exact pathology of the mitral valve on 2D imaging. This is an example of a patient with myxomatous or Barlow's valve. Diffuse excess tissue affects multiple segments, resulting in large floppy leaflets that are thickened and distended. Billowing of one or both leaflets is often seen. Diffuse chordal elongation can lead to chordal rupture. Severe annular dilation, annular calcification, subvalvular fibrosis, and calcification of the papillary muscles may be seen. In the dataset to the left, prolapse of the P1-P2 segment is visualized. On the right, please note the proximal isovelocity hemispheric surface area. Degenerative or myxomatous disease is the most common etiology of mitral valve prolapse. Patients with Barlow's disease are generally less than 60 years of age at the time of surgical referral. The disease is caused by myxoid infiltration, leading to a thickened and elongated, redundant myxomatous appearance of the valve that may lead to billowing and prolapse. Other findings include enlarged and lengthened chordae and mitral annular dilation. Early in the disease process, only trivial or mild regurgitation may be noted. As the condition advances, the regurgitation becomes progressive with the enlargement of chambers and progression to heart failure if left unrepaired. A flail leaflet is recognized when the free edge of the leaflet is completely reversed in the left atrium. Usually this results from a ruptured chordae and most frequently involves the posterior leaflet. A flail leaflet is usually associated with severe mitral regurgitation. Note that severe mitral regurgitation is rare with an anatomically normal mitral valve and apparatus. This is a case example from a patient with an ischemic cardiomyopathy. Ischemic heart disease is a common cause of mitral regurgitation and is suggested by the presence of regurgitation in a patient with coronary artery disease. Most commonly, it is seen with a previous inferior myocardial infarction where a wall motion abnormality prevents closure of the posterior leaflet or dilated left ventricle, resulting in mitral regurgitation from annular dilatation. Notice on this example, the P3 scallop is restricted, while the chordae has ruptured on the P2 scallop, resulting in a flail. Color Doppler demonstrates a large regurgitant orifice area. Functional mitral regurgitation occurs from left ventricle remodeling from a cardiomyopathy, which results in progressive mitral annular dilation and papillary muscle displacement. This prevents closure of the mitral valve, leading to central regurgitation. Notice that the valve appears normal. The dataset presented here represents a 3D transesophageal echo image of the mitral valve from a left atrial and left ventricular perspective in a patient with an ischemic cardiomyopathy. The P2, P3 scallops are restricted, creating a large oval-shaped regurgitant orifice with an eccentric anterior directed jet seen with 3D color Doppler. The biplane 2D color display highlights the limitations of PISA and vena contracta methods when obtained from a single plane. To correct for this, it is recommended to average the two perpendicular measurements. The following images demonstrate how 3D color Doppler allows for a more accurate geometric assessment of the regurgitant orifice. In this example, real-time 3- and 2-dimensional transesophageal echocardiography images demonstrate a normal functioning mitral annuloplasty ring. There are two common causes of mitral stenosis, rheumatic and degenerative. Rheumatic mitral stenosis is recognized by commissural fusion, chordal shortening and fusion, leaflet thickening, calcification. Clinical clues include history of rheumatic fever. Degenerative mitral stenosis is recognized by annular calcification as a main lesion. Clinical clues include elderly patients, hypertension, atherosclerotic disease, and sometimes aortic stenosis. Commissural fusion is not present. Mitral stenosis is the most common cause of inflow obstruction and is usually acquired as a result of rheumatic heart disease. Chronic scarring of the mitral valve leaflets over time leads to the following characteristic deformities: fusion of the leaflet commissures, thickening, fibrosis, and calcification of the leaflet cusps, creating a funnel-shaped or fishmouth stenotic mitral valve. Additional rheumatic involvement of subvalvular apparatus includes fusion, thickening, retraction, shortening, and calcification. The presence of these characteristics altered the normal, rapid, biphasic motion of the valve. The restricted opening of the diseased anterior and posterior leaflets result from reduced commissural separation from partial fusion and chordal foreshortening, therefore causing the leaflets to open with a doming motion. Immobility of the posterior leaflet can give the appearance of a hockey stick deformity to the anterior mitral leaflet due to leaflet tethering. These changes reduce the effective orifice area to less than 2 centimeters squared, which can obstruct diastolic inflow of blood to the ventricle. Remember, the normal area of mitral valve orifice is about 4 to 6 centimeters squared. The close proximity of the mitral valve in relation with the esophagus allows for excellent 3D transesophageal echo imaging to assess anatomy of the mitral valve and for more precise localization of the stenotic orifice. The in-face cross-sectional view of the mitral orifice allows more accurate and reproducible planimetry measurements. The fibrotic calcified valve is a better reflector of sound waves than the normal thin leaflet, which allows for higher frame rates and better image quality. Secondary consequences of mitral stenosis can include left atrial dilatation and flow stasis and tricuspid regurgitation. Right ventricular function should also be evaluated by echocardiography. Left ventricular function is usually normal in uncomplicated mitral stenosis. 3D echo assessment has been shown to be superior for grading mitral stenosis severity. Direct planimetry of the smallest orifice area by 3D echo is more accurate than 2D techniques and is not affected by the hemodynamic changes, unlike mitral valve area calculations by pressure half-time and continuity equation methods. They also have better correlation with invasive valve areas calculated by the Gorlin equation. Degenerative mitral stenosis is demonstrated in the 3D images with color flow from a patient with annular mitral stenosis. Note the heavy calcification protruding in the valve orifice at both the anterior and posterior aspects of the annulus. The tips are relatively free and the leaflets open without doming restriction. This is another example of degenerative mitral stenosis. Notice the extensive calcifications along the annulus which restrict mobility of the valve. This is much different than the fish mouth appearance seen with rheumatic disease. We will end with some interesting cases of mitral valve endocarditis. In this example, the bacteria essentially ate a hole in the valve. Mitral valve perforations are underdiagnosed with 2D images and more easily recognized with 3D imaging. This case example shows a mitral valve perforation as visualized from the left ventricle. Another complication that can be seen with endocarditis is aneurysmal dilation of the valve, which is quite severe in this case. Thank you for watching this presentation on 3D evaluation of the mitral valve. To learn more about the mitral valve and other topics in echocardiography, please visit mdtraining.com.